I'm Dr. Alexandros D, a neurological surgeon here at MedStar, Georgetown University Hospital. I focus on adult neurological surgical conditions. Those are conditions of the brain and spinal column, peripheral nerve also. The majority of my practice is focused towards the spinal column, which is the neck, mid-back, and low back. In the world of neurological surgery, there's an additional focus towards minimally invasive or tissue-sparing techniques. These techniques are an evolution of applying the microsurgical techniques that we developed for the brain in the 1980s, and we then applied them to the spine. But the concept is tissue sparing, quicker recovery, less scar tissue. Minimally invasive techniques continue to expand. The more we use them, the more we realize there's other problems that we can treat through these modalities. So if anything, the field is expanding and this concept of tissue sparing is being supported by the improved outcomes that we're seeing. I started in an era where I was fortunate to have come from a pure clinical basis. And then the tools that we have had that make our jobs easier, make diagnoses quicker, and allow us to really evaluate patients in a more efficient manner so that we can get them better. The focus, of course, is to enhance and improve quality of life. And in some individuals, that falls under the category of a surgical procedure. In many other individuals, it falls under other techniques to try to moderate or eliminate the pain. A benefit to coming to a practice based out of MedStar, Georgetown University Hospital is that there are many different individuals that have experience. More often than not, we find that the pain can be taken care of by modifying treatments and tailoring programs to those individuals. So the majority of patients that I see through individualized treatments with rehabilitation medicine doctors or pain management physicians and physical therapists, those types of techniques can usually address the pain through non-surgical techniques. The same basic principles and problems that we were faced with are still the same problems we're faced with today. It's just that our technology and our techniques enhance our ability to treat those conditions. What drew me into the field of neurological surgery was the demands of the field and also the focus towards perfection and the goal of always trying to reach perfection and the responsibility that comes with that. And I like that responsibility. The expectations on the first visit are from the physician. You should be able to outline your history, explain the symptoms, and then from my perspective as the physician, my job is to listen and understanding how the human body works, sort through the problem based on the narrative that the patient's giving to me. And even some insignificant symptoms that the patient is describing can be very informative. And the idea with the interview and the discussion is to work through the problem and try to identify areas that should be focused upon. And if there's further testing that is needed, order that. And another major factor, if not the most important, is educate the patient so that they will understand what the sequence of events will be. So they'll understand what we're looking for in the testing, and then also understand some of the options moving forward with the realization of either other avenues that need to be explored or to understand this is the treatment that's being recommended. So types of testings that we frequently will do start with MRI scans. Frequently MRI scans are ordered by other physicians, and when disc changes or abnormalities are identified, that usually signals to the physician that a referral to a neurosurgeon is appropriate. That's our start point. Frequently we need to expand on that information, and there are a variety of other imaging studies, x-rays, CAT scans, and other types of scans that we can do to enhance the information of the MR. There's also other techniques where there are nerve studies to try to identify how the nerves are functioning. And so these types of tests give us a more comprehensive understanding, a bigger picture of the different things that can be contributing to the patient's symptoms. trying to determine whether you're a candidate for surgery is really based on the idea of ongoing pain that's not controlled with non-surgical treatments. It needs to be understood that the vast majority of individuals, 95% typically, of people that enter the healthcare system with symptoms related to nerve problems do not require surgical therapies to control their pain. And that's typically dealt with through rehab or other non-surgical modalities. If those types of treatments are pursued and symptoms are continuing and it's a level that is affecting the individual's quality of life, that's the group of patients where surgery should be considered. Minimally invasive spine surgery is the general concept of tissue sparing and the understanding as we apply microsurgical techniques, which is an offshoot of the magnification and microneurosurgical techniques we used for brain surgery in the 80s. The understanding that applying that when dealing with the spine has benefit to the patient. It yields quicker recoveries, less scar tissue, and it can be done in a way that it typically will not create other problems that might destabilize the spine or lead to further surgeries. Most conditions do respond to some version of minimally invasive techniques, and it should be understood that minimally invasive techniques are different in different conditions. So this can be a term applied to decompression, which means getting pressure off of the nerves, disc procedures, again getting pressure off the nerves, but there's also variations for spinal fusion procedures, and there's also versions of minimally invasive for deformity surgery, scoliosis surgery. But it's the concept that we can achieve the same, if not better, outcomes through less trauma to the body. Benefits of minimally invasive or tissue-sparing procedures involve quicker recovery and less scar tissue longer term. On a near-term basis, that allows us to be able to treat most surgical patients that have minimally invasive techniques on an outpatient basis. That can include techniques where we're doing simple decompressions and disc procedures, but we're even advancing techniques of spinal fusion operations where we're putting screws and rods in. We're also finding that a more expansive technique beyond just the surgical approach, certain medications that we can give before surgery, medications during surgery, and medications after surgery that will give certain amounts of pain relief for days, minimizing the need for opiates or pain medications, can enhance the recovery, and these types of benefits can then allow us to start therapy and rehab at a sooner point in time than might be otherwise possible. From a surgical perspective, in today's day and age, most individuals are candidates for minimally invasive techniques, tissue-sparing techniques. Clearly, there are situations where that's not appropriate. Some types of spinal deformity surgery, which is scoliosis, types of tumor procedures, trauma victims, destructive problems of the spine, those are not necessarily treated through minimally invasive techniques. With that being stated, however, we're now understanding that tissue-sparing concepts can still be applied in those individuals. So there is a variation on what would be considered minimally invasive that still benefits the patient, even in with those procedures that we consider more extensive or of wider exposure. After surgery, we're also having an expanding understanding of the benefits of physical fitness and activity, where there had been a perception in the past that if there was something surgical, you were going to need to curtail physical activities or avoid certain physical endeavors. We now understand that staying physically fit and staying active is going to be very important. Strengthening the muscles along the spine, letting the muscles and the tissues continue their balance and doing their fair share of the workload actually minimizes the chance of future problems and minimizes the chance of future surgeries. And that's a team approach where we typically will use the input in care under the direction of a rehabilitation medicine specialist who can focus on the types of strengthening, the types of conditioning and flexibility that each individual needs. By definition, if a lot of these changes occurred prior to surgery, then it's reversible. So many of the limitations that we used to place on patients were actually artificial limitations, and our colleagues in the rehabilitation medicine world show that these are by definition reversible. There can be some modifications of physical activities, but arguably that's just being smarter about exercise. So certain things that we might have done earlier in life that we got away with, we now find you go to the gym, you exercise. Maybe there are some exercises that aren't ideal for the spine, but we want you to stay physically fit and active. If anything, the most important thing in minimizing future problems is to exercise, stay physically fit, stay active. During postoperative recovery, one of our greatest resources is our physician assistants. They're very experienced, so they're available, as mentioned, accessible to patients to answer questions. There is a close working relationship, so even during times when the physician may not be in the office, taking care of other individuals and patients, the physician assistants are there, available, and if there's a need for communication, there are methods to allow that to occur. Again, enhancing the recovery of the patient during the postoperative recovery. In my practice of neurosurgery, I've been faced with certain situations where I recognized that there were more efficient methods and safer methods to care for the patient and enhance their outcomes. I've been fortunate that some of these insights have allowed me to obtain patents. Other avenues and other problems have also allowed me to collaborate with colleagues from other institutions around the United States, where we developed certain types of implants focused towards motion preservation in the spine, as well as other techniques and other design features which increase the accuracy of implants that are used, even those with fusion. Other innovations as far as the care of the patient with a spine problem can be understood when one looks at motion preservation. Certain types of problems, when it came to the spine in the past, the patient was only given the option of fusion. There has been work literally over decades trying to develop artificial disc technology, motion preservation technology, and we've achieved that. In the cervical spine, there are now devices which have been proven to be superior to fusion, and those have been coming out in the last 5 to 7 years. In the lumbar spine, there are other motion preservation technologies, understanding clinical trials that are ongoing here in the United States with devices that also are holding up long term, and offering those to the patients so they know what their options are, not only on a near term but a longer term basis. It's very important to understand that the physician should have the skill and the ability to understand innovation, techniques, and when some of those techniques are applicable and when they actually do not need to be undertaken. For example, our experience with the laser in spine surgery in the 1980s led to an understanding where it worked and other places where it was limited. And also understanding that although the laser was an option, there were certain techniques that were far superior. So that just because we could use the laser, it was not in the best interest of the patient. Also understanding, given anatomy, that there are techniques which were very successful but have now been superseded. So certain things we did even 15 or 20 years ago, which we thought were quite beneficial, we started to see the problems, and we now understand that some of the large procedures or maximal exposure procedures that we thought were so beneficial to the patient, we now understand we shouldn't apply those things. The concepts of treatment are the same, but we can achieve those goals without the trauma, without the long recoveries that we just automatically assumed were necessary even 10 or 15 years ago. When it comes to seeking treatment with a neurological surgeon, it's important, I think, to understand it's a team. The physician is one part of the team. The patient is the more important part of the team. So there should be a comfort level from the patient that the physician is able to understand and communicate and guide the care in the best interest of the patient.